Welcome back to the Anatomy Deep Dive. I'm Dr. Khan, and joining me is the ever-precise Dr. Sarah. Today, we are looking at a tiny strip of tissue that carries the massive responsibility of literally building our height, the epiphyseal plate. Dr. Sarah, I'm feeling energetic today because this isn't just anatomy, it's a race against time.
It certainly is, Dr. Khan. While you're focused on the race, I'm focused on the mechanics. For our students listening, the epiphyseal plate, or growth plate, is the primary site of endochondral ossification in long bones. It is high yield to remember that this is composed of hyaline cartilage, not fibrocartilage, and it's what allows for interstitial growth, or lengthening.
I love that. I always tell my residents to think of the epiphyseal plate like a construction crew on a highway. The crew is laying down a temporary wooden framework, that's your hyaline cartilage, and then the pavers come in behind them and replace that wood with solid concrete, which is the bone. As long as that wooden framework keeps moving forward, the road keeps getting longer.
A good analogy, but let's anchor that in the terminology the boards will test. The road you're talking about has specific regions. The shaft of the bone is the diaphysis, and the ends are the epiphyses. The growth plate sits between them, specifically abutting the metaphysis. The metaphysis is the part of the diaphysis that is actively undergoing change. If a question asks where the most metabolically active part of a growing bone is, it's usually the metaphysis side of that plate.
Exactly. And why does this matter clinically? Because in a child, that wooden framework is the weakest link. If a kid falls off the monkey bars, the ligaments and tendons might be stronger than that hyaline cartilage. The bone is more likely to crack right through the growth plate than to dislocate a joint. If we miss that on an X-ray, we're looking at a permanent growth arrest.
Precisely. And speaking of X-rays, on a standard radiograph, the epiphyseal plate appears as a radiolucent line. To an untrained eye, it looks like a fracture. You must correlate the image with the patient's age. For the boards, remember that these plates typically close between ages 18 and 25. If you see a fracture line in a 10-year-old that perfectly matches the anatomical location of a growth plate, it's likely just normal development.
But here is where it gets wild: infection. Dr. Sarah, I've seen cases where osteomyelitis or even a nearby tumor increases the blood flow to the area. Because the growth plate is so vascularly sensitive, that extra blood can actually overstimulate the construction crew. The wood is laid down faster, and you end up with one leg that is significantly longer than the other. It's a clinical paradox. Trauma usually shortens the limb, but hypervascularity can lengthen it.
That's a great clinical pearl. Let's pivot to a high-yield pathology often tested in pediatrics, rickets. In rickets, we see defective mineralization of that cartilage matrix. Because the matrix doesn't harden properly, the cartilage cells just keep proliferating without being replaced by bone efficiently. This leads to a classic board exam finding, the widening of the epiphyseal plates. You'll see cupping and fraying at the metaphysis on X-ray.
And the clinical consequence of that soft matrix? Bowing. The bones are literally too soft to support the child's weight, so the femurs curve out like a pair of parentheses. It's heartbreaking to see, but it really highlights why the chemistry of that hyaline matrix is just as important as the anatomy itself.
We should also mention the role of hormones and diet. Vitamin D, calcium, and even endocrine disorders like growth hormone imbalances can completely disrupt this plate. From a board perspective, any disorder that affects hyaline cartilage will eventually manifest at the epiphyseal plate. It's the most sensitive sensor for a child's systemic health.
You know, when parents bring their children in after a fracture, they are terrified about their kid's future height. As a clinician, you want to be their doctor of choice by explaining these risks clearly. If the blood supply to the epiphysis is compromised, say from a displaced fracture of the femoral neck, the cartilage dies. No cartilage, no growth, period. The construction crew has gone on strike, and the road stops there.
And let's clarify that for the exam. Hyaline cartilage is largely avascular in many places, but the epiphyseal plate depends on the nutrient arteries from the diaphysis and the epiphyseal vessels. If you're asked why a limb is shortened after trauma, the answer is often ischemic necrosis of the epiphyseal cartilage or premature closure of the plate.
Wait, I have to throw in one more analogy. Think of the growth plate like a zipper. It's zipping the epiphysis and the diaphysis together while simultaneously pushing them apart to make the bone longer. If you get a piece of gravel in the zipper, like an infection or a shard of bone from a fracture, the whole mechanism jams.
And once it's jammed, it's often permanent. Hyaline cartilage has a notoriously poor capacity for repair. When it's damaged, the body often fills the gap with fibrous tissue instead of new cartilage. That fibrous bridge creates a bony bar that prevents any further expansion.
Why does this matter clinically? It means we have to be aggressive. If there's a slip of the epiphysis, like slipped capital femoral epiphysis or SCEF, we don't just wait and see. We have to stabilize it surgically to protect that plate. We are literally protecting the patient's adult height in the operating room. Excellent point. Let's wrap this up for our listeners. To summarize the high-yield facts, 1. The epiphyseal plate is made of hyaline cartilage and is the site of endochondral ossification. 2. It is located between the epiphysis and the metaphysis. 3. Fractures here are common in children and can lead to growth arrest. And 4. Systemic issues like rickets will cause the plate to widen due to poor mineralization. And from the clinical side, always treat a growth plate injury with the utmost respect. It's the engine of the skeleton. If you keep the construction crew happy and the blood flowing, the patient will reach their full potential. Great session, Dr. Sarah. We'll see everyone next time when we dive into the mysteries of the synovial joints.